and Priya. So I have a task of covering up lymphomas and its mimics in the next 45 minutes or so. Briefly, for lymphoma diagnosis, we know as any other tumor, it's a multidisciplinary. For young beginners in pathology, please consider first 3 lines very, very important: history, clinical and hematology, biochemistry, routine tests in the lab. Very important is history and clinical. Because as you start reporting pathology, you realize that you cannot sign out many tumors if you do not have age in mind or other clinical features. And then we have the techniques, like immunophenotyping, which detects the proteins, cytogenetics for chromosomes, and molecular diagnostics at the gene level. And many a times we need even radiology to help us, to give us a push to diagnose maybe a T-cell lymphoma or another lymphoma. So broadly, lymphomas, we can say that Hodgkin's and non-Hodgkin's. Though it's a debatable to call it like Hodgkin's, they are all lymphomas. So, but we just call them Hodgkin's because they have some special cells. We'll talk about that. And if you ask me which are the common lymphomas in our practice, which we see, if you read any book, let's say WHO book or any other textbook of hemat, lymphomas would be 500 types and leukemias will be another 400 types. But the common ones for a postgraduate or for a practicing pathologist for adults: diffuse large B-cell lymphoma, classical Hodgkin's, follicular lymphoma, and PTCL and AITL are the common lymphomas. In children, Hodgkin's, followed by T lymphoblastic lymphoma, which comes in mediastinum emergency, Burkitt lymphoma, and ALCL. So if you look at this, Hodgkin's come in both the age groups, adults as well as children, and it's extremely common. Almost every third case in my practice, almost every third or fourth case is Hodgkin's lymphoma. It's the most easily diagnosed lymphoma because we all read classical RSLs in a milieu. So we diagnose Hodgkin's easily. 15 years back or 10 years back, we didn't do many IHCs also. As 15 years back, we did limited IHCs. But as we started learning the disease more and more, and the mimics more and more, our panels have increased now. And because we are very scared now to call RS-like cells in a lesion as a Hodgkin's lymphoma, because we will see today RS-like cells can be seen in many other lymphoid lesions, benign also and malignant also, which are not Hodgkin's. So Hodgkin's lymphoma for many years has been called as Hodgkin's disease. The reason is the tumor cells are very few, so it was thought as an inflammatory lesion, so called as Hodgkin's disease for many years. So if you remember your pathology of Hodgkin's, the tumor cells are 1%, 2%, hardly, or less than 1% sometimes. They're very few. They have large immune background of lymphocytes, plasma cells, eosinophils, polymorphs, histiocytes. But the tumor cells are far scattered, one odd here and there. Rarely you get sheets and clusters of tumor cells in Hodgkin's, rarely. So broadly, the Hodgkin's lymphoma is of 2 types: classic Hodgkin's lymphoma and NLPHL. Now, classic Hodgkin's lymphoma has been traditionally divided into 4 types, out of which the 2 common ones are mixed cellularity and nodular sclerosis. The lymphocyte-rich classical is less common, and lymphocyte-depleted is extremely uncommon. I do not remember when I signed out a case of lymphocyte-depleted in my practice. Maybe I've seen 1 or 2 cases in my entire 23 years in Tata Hospital. So the common ones are these 2, mixed cellularity and nodular sclerosis, followed by lymphocyte-rich. Now, lymphocyte-rich classical has some similarities with NLPHL, some. Now, these two entities, which are parts of Hodgkin's, they are very similar, but they are different. So there's a lot of debate between the lymphomaniacs, between the different groups, whether to keep NLPHL in the category of Hodgkin's or should be kept into the category of low-grade B-cell non-Hodgkin's lymphomas, because it is basically NLPHL is a B-cell lymphoma with preserved, B-cell program. Hodgkin's lymphoma is also a B-cell lymphoma where the B-cells are mutated. As you will see, the 20 is mostly negative. So we need transcriptional factors like PAX5, OCT2, BOB1 to call it as a B-cell origin for classical Hodgkin's. So they are similar entities. They have some differences, but as of now, both belong to Hodgkin's lymphoma. In the present classification by WHO, they belong to Hodgkin's lymphoma. I'll quickly go through 4 or 5 cases, then we start working on more detailed cases. Young boy, big mass, left cervical node. So you see it's a diffuse pattern of involvement. Node looks pink. Basically, when you say pink, it means that more histiocytes, more polymorphs, more neutrophils, more eosinophils. Tumor cells have larger size. If you see here is a nice polymorphous background, you could see some eosinophils and some tumor cells. Here also you can see some tumor cells. Like these are the tumor cells. There may be mononuclear, and there are these eosinophils here. There are these histiocytes. There are many lymphocytes. So it's a kind of polymorphous background, mononuclear tumor cells, binuclear tumor cells. Maybe it is Hodgkin's because it's going RS-like cells. The classically RS we define binucleate, prominent eosinophilic nuclei, but many times you don't see classical ones. Here also you see on the top. Yeah. Go to the next case. A young boy, 2 by 2 centimeter node, removed cervical node. If you see here, the large node, there are some follicles residual here. The rest looks like a expansion of the interfollicular zone. So maybe you call it paracortical zone or interfollicular zone is expanded, looks pink. And if you look here again, it looks pink. This is maybe a residual follicle with the mantle inside the germinal center. But this area is expanded, paracortical T zone. Here also you see a lot of histiocytes. Again, it looks pink because of histiocytes. Maybe this is a secondary follicle here, but the rest is all T zone or interfollicular zone with some large cells scattered and a lot of histiocytes. If you come to the high power, maybe 20x, you see many mononuclear cells like this. Many. Here also, you can find some cells like this mummified, and many mononuclear cells which may resemble, some of them may resemble immunoblasts, and there are eosinophils like this eosinophils, and many lymphocytes, small, and some lymphocytes look atypical, slightly largish in size. So Hodgkin's can have background where the lymphocytes can look slightly largish, maybe some atypical. So there comes the confusion when you have to differentiate it from peripheral T-cell lymphomas, especially in adults. So we'll see that. So in high power, you see this prominent nuclei, binucleate cells, prominent eosinophilic nuclei. These look like more like RSS, lot of eosinophils. You can see this granular cytoplasm. These are all eosinophils. This one, RS cell. So if you do 3 and 20, which are the, I think, 2 stains a postgraduate should know, CD3 and CD20, every PG should know these 2 stains in hematopath. More than that, if you know, it's very good, but these are the 2 mandatory stains. You look at 3. Now the whole slide is CD3 positive. It looks brown. The brown is the color of the IHC stains we use. And you see every small cell is 3 positive. In the high power here, most of the cells are 3 positive. And this is RS cell, which is negative. However, there are small lymphocytes, which can kind of forming a rosette around the tumor cell. So again, you see all 4 slides in this picture are CD20. Now CD20 is highlighting secondary follicles. These are small lymphocytes. And if you see carefully, there are RS-like cells, large cells, which are positive. They are weakly positive. When you say weakly, it basically means you compare this intensity with the intensity of normal B cells. Normal B cells look very bright for 20. but the tumor cells look very weak. You see this weak. So this is the beauty. So Hodgkin's disease, 15-20% of Hodgkin's RSS can express CD20 weakly. Now, if you see a beautiful cell here, RS-like cell here, this is CD20 negative. So in the same case, you have some cells which are 20 positive, some are weak, some are moderate, and some are negative. You have to be a little careful. There could be some immunoblast also in the background. B immunoblast will be CD20 positive. So one has to be careful how to differentiate B immunoblast from RSS, both on HND and also on CD20 and CD30. Look at this EBV. This is a virus, Epstein-Barr virus. The best marker would be to do EBER-ish, which is a little expensive, so we generally do it as a second panel. In the first go, we go LMP1, and most of our Hodgkin's mixed cellularity are EBV LMP1 positive. Nodular sclerosis are mostly negative. So you look at 30, this is large cells. You can see these abnormal cells. The other ones are the cute looking mononuclear. I'm not sure of RS. This looks like RS. I'm not sure. So these stains also give you a morphology, whether you're dealing with the binuclear cells or bizarre looking cells, giant cells, or immunoblast like cells. So now if you ask me, what is this cell? This may be a plasma cell. So plasma cells express CD30 and they are the internal control for CD30. So plasma cells and immunoblast, B immunoblast are the internal control for CD30 markers. So whenever you call CD30 negative, you have to see at least few cells positive in the lymph node, which would be immunoblasts and plasma cells. If you find no cells positive, it basically means your IHC has not worked well. Maybe you need to repeat. So the best control is inbuilt internal control, not the extra slide put from outside. Now I look at this PAX5. Now this is a beautiful marker which saves our, the day. And you see this is the germinal center, secondary follicle, nicely positive for all B cells. Here also some B cell aggregate of maybe mantle cells. And if you look at here, these are the large size tumor cells. They are positive. And if you look, they are weakly positive in comparison to the normal B cells. So this is a classical weak positivity, nuclear weak positivity of PAX5. Even CD15 is positive. Now CD15, you have to be careful. It's also positive it's a myeloid marker. So it can come positive in myeloid CD cells, even histiocytes. So the background cells, this is not RSL. This is a myeloid cell, maybe eosinophil or a neutrophil. This one is not a RSL. But yes, this is RS. This is RS. You can see the morphology. You can see clearly the nucleus. You can see the Golgi, the membrane, even the cytoplasm. What a third case, young lady, cervical node. You can see some blue areas, possibly residual mantle or follicles. The rest is very pink. Again, interfollicular zone pink. You see the RS-like cells, many eosinophils. You do stains. These are your eosinophils and possibly RS-like cells. Again, 3 is rich in the background. The 90% cells are CD3. So if you think that the small cells are neoplastic, then this becomes peripheral T-cell lymphoma. But if you think these are the neoplastic cells, then maybe we are dealing with Hodgkin's. So it's very important as a pathologist to select cells of interest. Which are your cells of interest? If I select small cells, because peripheral T-cell lymphoma will also show you many immunoblasts, which can look like RS cells. Peripheral T-cell lymphoma can also show you many histiocytes, many eosinophils. And peripheral T-cell lymphoma, the background small lymphocytes can look innocuous. They can look benign in morphology. They don't look very malignant. So one has to be very careful. And here we have problem in our day-to-day reporting, and we can discuss that. And if you look at 20 here, 20 is negative in the large cells, very few. So Hodgkin's classically is a B depleted node. There are mostly T cells. B cells are very few in the background, classically in Hodgkin's. You look at 30 strongly positive. PAX5 is weak, Hodgkin's. Another young lady, cervical node. Here it's beautiful. You can see the thick capsule. I must give credit to and thanks to my DM student, Divakar, who worked hard today. Divakar and Tushar, they helped me take pictures of new cases of Hodgkin's and non-Hodgkin's lymphomas. Hodgkin's. So if you see, this is a whole node. This is a thick capsule. There are fibrotic bands going inside the node, all these. So on the low power, you know that there are these nodules. You are dealing with a Hodgkin's lymphoma, nodular sclerosis. This looks like that. Just to confirm, you go to the high power. Actually, in the low power itself, you can see these RS cells. You don't have to go to high power. You can go to the scanner. Even scanner will give you the diagnosis. All these are these clusters of RS cells. In the background, there are lymphocytes. This all is fibrosis. Again, fibrotic bands, nodules. These are the nodules. So we are dealing with classical Hodgkin's lymphoma, nodular sclerosis, and these are lacunar cells which have clearing around them, like spider web. If I have high power, these are like multinucleate giant cells, like these are spider cells, like spider web cells. Here. So these are all the multinucleate, bizarre looking tumor cell, binucleate. This is not immunoblast. No, this has to be tumor cell. So morphology is important. Just do not pick large size mononuclear cells. They could be immunoblasts. Look for bizarre morphology. Look for CD30 positivity in large cells, multinuclear cells. Now, this is the background of Hodgkin's, which is rich in lymphocytes and many lymphocytes. 90% cells are all small lymphocytes, and they may show mild atypia. Look at this. They look slightly largish, slightly atypical. So Hodgkin's can show you some mild atypia in the background, small lymphoid cells. One has to be careful. Now, there is a large cell here. There is a mummified cell here, mummified cell here. 3, as I told you, rich. 3 is rich. 20, you see, this is 3. Again, now if you look at CD20, it is depleted. Very few 20 cells. The large cells are all negative. These are negative. You have to see, there are negative. For me to call a cell a positive, it has to be all around the cytoplasm membrane, if it is a membrane marker. But here, do you see the tumor cells are negative? No. So 30 is positive, and look at the 30 is all positive in Golgi, in the cytoplasm, also in the membrane, all 3 areas. This all is 30. So 30 is positive beautifully in this case. 15 is also positive. Now 30 is the classical. It has to be positive in all Hodgkin's. If 30 is not positive, you don't call it Hodgkin's. Take a second opinion. Maybe do more workup. So 15 is positive in almost all, but maybe in 60 to 70% of Hodgkin's. Not all. Then you do Epstein-Barr virus. As I told you, it is negative classically in nodular sclerosis. It is negative here. ALK1 you do if you find the tumor clusters are many, because ALCL is a common differential. If it's a young kid, you have to keep in a ALCL. Though this doesn't look like ALCL, it looks more like nodular sclerosis. And PAX5 is weakly positive. Did I show you PAX5? I think I missed out in this. It was weakly positive. 16-year-old girl left cervical node. Another case, nodular sclerosis. Nodules, band. RS-like cells you see here, lacunar cells. And 30-15 positive. Next case, cervical nodes, FNEC was done. This is a PAP stain, very popular. We do FNEC, most colleges, we do FNEC first. Any lymph node we find. There are large cells here. There are large cells, scattered eosinophils in the background. Again, large cells. And there are some eosinophils here, some neutrophils, lymphocytes, but RS-like cells, mononuclear, multinucleate. If you do, sometimes, rarely, they go to the bone marrow. Very rarely, you can pick them up on the bone marrow. And if you have a good lab, if you have somebody like Prashant working with you, you can pick up RS-like cells even on the flow. You know, I'm not going to go into details, but just to tell the postgraduates, you could pick up RS cells on flow by using some markers, you know, yeah. But only in the expert's hands. Hodgkin's is still diagnosed based on morphology of a whole node biopsy with a panel of markers, not by flow, not by FNEC. You'll make mistakes if you do only FNEC and make a final diagnosis of Hodgkin's. I'm showing you a case of Hodgkin's where the bone marrow is done in all lymphomas for staging purposes. Staging. So bone marrow here was done, and you see this is normal marrow, this is a bone, trabecular, this is some kind of deposit here. This looks like a normal marrow with fat. This is all its tumor till here. It's a lymphohistiocytic lesion again, and scattered large cells are there here. If you do CD30, they are positive. Again, another case of bone marrow biopsy involving, these are the nodular deposits. So bone marrow shows classically nodular deposits of Hodgkin's, which are difficult to get in the aspirate. So Hodgkin's are best picked up on the trephine, not on the aspirate. You have to be very lucky to pick them up on the aspirate. Here you see so many eosinophils. Another case, a 64-year-old female, you know, large node, maybe 2.5 centimeter covering the whole slide, many follicles, and some of the follicles are bigger nodules, like these big nodules. Now, when you see these big nodules without a germinal center, like these, you see the germinal center, the mantle, here also, a prominent mantle or marginal, nice follicle. But this is not a follicle with germinal center. It looks as if the germinal center has gone inside. The mantle cells have gone inside. Maybe the margin cells also gone inside the follicle. Maybe the follicular lysis, and they become a big nodule called PTGC, progressive transformation of germinal center, PTGC. Yeah, progressive transformation of germinal centers. This is very common findings in cervical nodes. If you are practicing breast pathology or head and neck pathology, you'll find one of the nodes showing PTGC-like features if you remove 20, 30 nodes. Now, as a pathologist, your job is to now look for any suspicious cells, any tumor cells in this nodules. Within the nodules or maybe outside the nodules. If you find any suspicious looking cells, which we call Elenit cells or popcorn cells, which are type of RS, we give a label of NLPHL. Then we call it nodular lymphocytic predominant Hodgkin's lymphoma. If you do IHCs, these nodules are 20 rich. They are rich in 20. They don't have germinal centers, but their nodules are 20. These are normal follicles. They are also 20 rich. And these are the abnormal nodules. These are also 20 rich. And if you see the large cells, they're also 20 positive. The large cells, which are like popcorn, I'll show you better pictures. They're all positive. CD3 might form the rosettes. And if you are lucky to have other markers, you can find rosetting of these tumor cells by T follicular helper cells. So you could do, apart from 3, you could do 4, BCL6, PD1, and you can see the PD1 rosetting the tumor cells. 30 is classically negative. Now, this is some pigment. This is not positivity. 30 is negative in the large cells, 15 is negative or weakly positive. 30 could be weakly positive. EBV is classically negative, rarely can be positive. CD21 can highlight your nodular patterns. These are the normal follicles here. This looks like the lesion. PAX5 will be positive, strongly positive, not weak here, because this here the B cell program is preserved. So here 20 is strong, PAX5 is strong. Unlike classical Hodgkin's, where PAX5 was weak and 20 was mostly negative. Another young lady, a young boy has got a nodule here. There's a big nodule. There's another nodule going this side. And if you go to the high power, there are some tumor cells in the nodule. They are classically strongly for PAX5 and 20 also. These all are 20 positive tumor cells. And if you look at the history, a young boy, left inguinal node, a large node, no B symptoms. So this history tells you it's NLPHL. Now, NLPHL has a classical history, a large node, maybe 1 year, 2 years duration, classically inguinal, axillary, large size, 4 centimeter, 5 centimeter, 6 centimeter, firm. And the patients are asymptomatic, no B symptoms. Rarely they are stage 3 or 4. They are mostly 90-95% cases are stage 1A. So, these are NLPHLs. Many patients are just observed or given rituximab or very low dose therapy. So if you look at this picture, it shows you types of RSS, mononuclear, binuclear, multinuclear, mummified. Thanks to the WHO Heme5, I've taken this picture from there. And you do these stains, as you see here again, rosetting of T cells in classical Hodgkin's. In NLPHL, it will be follicular T helper cells. In classical Hodgkin's, it will be just T cells. It won't be T follicular helper. So they won't express PD1. But in NLPHL, they will be expressing PD1, CD4. Now, going to the mimics now, the related entities of Hodgkin's. Common ones are these two, PMBCL and gray zone lymphoma. Both occur in mediastinum. So I'll quickly go through cases. This is a classical case of gray zone lymphoma, which we called Hodgkin's. It is a very old case, almost 15 years old case. We called it Hodgkin's based on the tumor cells expressing, 30 weekly, 15 scanty tumor cells. 15 was positive, 30 was positive, 20 was positive. We called it Hodgkin's. Patient was given chemotherapy, came back after a year with a large mass, and now the tumor biopsy was redone, and you see the sheets of tumor cells. They don't look like classical RS, though some of them have a prominent nuclei, thick capsule. So we thought it's a relapse of Hodgkin's, but it was strongly 20 positive, 30 positive again, and 15 positive. So it was basically a case of gray zone lymphoma. So gray zone lymphoma for postgraduates is a lymphoma, occurs in mediastinum, mostly. Looks like Hodgkin's, but is strongly positive for CD20. the B cell program is preserved. So if you have Hodgkin's lymphoma in mediastinum or supraclavicular lymph nodes, supraclavicular is a part of mediastinum. So if the Hodgkin's lymphoma expressing 20 strongly, you should think of gray zone lymphoma, because Hodgkin's do not express CD20 strongly. They don't express. If they express weak to moderate, weak. This is another case of primary mediastinal large B cell lymphoma, a needle core biopsy, very old case. Again, fine fibrosis, nesting, foamy cells having clearing of the cytoplasm. You do 20 LCA, 30 and 23 weakly positive, 20 strongly positive. Classically primary mediastinal large B cell lymphoma. Now, another entity which is very closely associated with Hodgkin's lymphoma is classical Hodgkin's lymphoma is immune deficiency and dysregulation settings. Means like HIV. So you have lymphoid proliferation in HIV may mimic Hodgkin's. Post-transplant, drugs, they all may mimic EBV positive classical Hodgkin's lymphoma. So here it's extremely important in Hodgkin's to take history also and site, because we do not diagnose Hodgkin's at extranodal sites. Hodgkin's is almost always nodal, supra above the diaphragm. Hodgkin's is almost always nodal and above the diaphragm. Extranodal sites only in stage 4 in the known cases of Hodgkin's. So primary Hodgkin's of GI, you don't diagnose, of GI tract, no. It may be mucocutaneous ulcer. It could be something else, which mimics Hodgkin's. I'll give you 2 examples. A young boy, immunocompromised patient, dysphagia, there is an esophagus, ulcerating lesion. You see the esophagus, there is an ulcer here, this is a ulcer slough. If you come here, there are RS-like cells, there are lymphocytes, RS-like cells. You do IHCs. 3 rich background, 30 positive, EBV positive, 15 positive, and PAX5 is also positive. PAX5 is weak to moderate, you see this. There can be moderate, weak. So it looks like Hodgkin's, but it is in esophagus, ulcerating lesion, known immunocompromised young boy. So we told the physicians to stop the immunosuppression, and the lesions got cured. So you don't have to call it Hodgkin's and give chemotherapy here. So mind you, do not call it Hodgkin's at the mucosal sites. Avoid it, take adequate history, and look at if patient is immunocompromised. Another case, rheumatoid arthritis on drugs, methotrexate, now a bronchoscopic biopsy. Same thing here, ulcer somewhere, large cells scattered in the inflammatory background. If you do IHCs here, there are many large cells. Bronchoscopic biopsy. If you do IHCs, these will be positive for 30, 20 EBV. They are, and they're also PAX5 positive. EBV positive, 20 positive, large cells. EBV full. So PAX5 also positive. So these was again EBV positive mucocutaneous ulcer. So I've shown you 2 cases of EBV positive mucocutaneous ulcers which can mimic Hodgkin's, and they occur at the mucocutaneous sites. So a very important slide is a poor quality, very old slide, but just to show you that all that glitters is not RSL. So CD30 if positive in large cells, it is not RS. They just could be immunoblast, could be EBV carrying cells, could be plasma cells. They might not be tumor cells. So based on 30, don't make diagnosis of Hodgkin's. Sometimes you are doubtful on morphology. It is Hodgkin's or not Hodgkin's. You do 30, 30 is positive. It doesn't become Hodgkin's. You still remain the doubtful because immunoblast will also be 30 positive. So you have to make up your mind based on history, clinical, all morphological findings, and not alone 30, multiple markers. I'll show you a semi-classical case of Hodgkin's now. Young boy, cervical node. You again see some mantle zone cells, blue area, and the left again expanded paracortical or interfollicular zone with large cells, sheets of large cells, mummified, multinucleate, mononuclear, and eosinophils in the background with neutrophils. So what we did 3 stains, LCA, 3 and 20. LCA is positive in the mantle zone, 20 is positive in that zone, but the large cells are negative for LCA, negative for 3, negative for 20. So what do? Is it a carcinoma or is it anaplastic large cell lymphoma? So what we did, this is the morphology. So but we've not done 30 till now. So you do 30, look at 30, it's beautifully, strongly positive, all membrane, Golgi, cytoplasm, all. 15 is beautifully positive, PAX5 is positive, ALK is negative. So this is a case of classical Hodgkin's lymphoma, which has a lot of tumor load. Again, a rare, but you should keep in mind, Hodgkin's sometimes can come with heavy tumor load. So now, how do you define Hodgkin's? Now, this is a beautiful definition given by, as written by Anita and her group in the Hodgkin's lymphoma chapter for the WHO book, Anita Borges. If I read it for you, classical Hodgkin's lymphoma is a neoplasm derived from germinal center B cells, characterized by scanty tumor cells embedded in reactive microenvironment, rich in immune cells. So we don't call them benign cells, we call them immune cells, lymphocytes, plasma cells, eosinophils, histiocytes. And the large number of neoplastic RSLs show a defective B cell program, which we have seen, they are 20 negative. So this is a beautiful definition of classical Hodgkin's lymphoma. To call Hodgkin's, you have to have classical RS and a classical milieu. You need to see eosinophils, polymorphs. You don't see eosinophils, hold on. Thick capsule, nodular pattern, multinucleate giant cells. Then you look at 30, PAX5, 20, and call it. Now, this is a case which mimics Hodgkin's, but this is a sinusoidal pattern of a case of anaplastic large cell lymphoma. It was ALK negative, only 30 positive. 30 positive, PAX5 negative, ALK negative. You need to do more workup for other transcriptional factors, like as I told you, talk to BOB1, GATA3, few more, and maybe CD4 EMA or some T cell markers for ALCL. So I have 3 slides for important notes in Hodgkin's, which I think I would like to share with you. Clinical is very important. As I told you, history, site above the diaphragm, external sites, no Hodgkin's. Morphology, capsule thick, fibrotic bands, nodules. It's a lymphohistiocytic lesion, very pink looking node, polymorphous background with lots of eosinophils. RSLs, giant cells, multinucleate giant cells, and variants. And IHCs, all these IHCs. So if you look at new WHO, they mentioned so many markers, but in the new WHO, we have also the essential criteria apart from the desirable criteria, where at least these 3 markers, if you're working in very rural, nobody works in rural setting for Hodgkin's lymphoma and doing IHCs, but you need to do at least these 3 markers, 20, 30, and PAX5. In our practice, I do 6 markers upfront. If I have a doubt, then I add markers. So these are the 6 markers which I and my colleagues do. So about the pathogenesis, I have only 1 slide. I have mostly slides of the pictures. If you look at this, it's basically 2 things, tumor microenvironment and immune evasion. The RS cells, they secrete large number of cytokines and chemokines and attract the other immune cells. And these factors help them in survival, proliferation, and differentiation processes. Similarly, the RS cells, besides they attract the T regulatory cells, they also suppress the cytotoxic T cells and NK cells. Here you see. And lead to secretion of immunosuppressive factors. So these are the predominant pathogenic 2 factors, tumor microenvironment and immune evasion. Other few important points to note in classical Hodgkin's, I have told you these points. Primary is rare, mostly nodes and above mediastinum, and RS cells can be seen in many conditions, benign as well as malignant. RS cells are classically LCA negative, very important. ALCL is also LCA negative, and RS cells are 20 negative. CD30, as I mentioned, is also positive in many other immunoblasts reactive. Diagnosis of PAX5 negative classical Hodgkin's has to be made with caution. You need to do more stains and work up at least 2 or 3 B transcriptional factors. Classical Hodgkin's lymphoma has a very rich T cell background, so do not call it peripheral T cell lymphoma either, and vice versa, except lymphocyte rich classical Hodgkin's, which might show you a B cell predominant. Many lymphomas which show you RS-like cells, do not call them composite lymphoma. We'll see that many lymphomas have RS-like cells. So when you report a lymphoma or a Hodgkin's or any other lymphoma or any tumor, the important thing is what are the cells of interest? The tumor cells may look large, may look small, may be small, and the large looking cells may be benign. So the large cells do not become malignant, and the small cells not necessarily will be benign. Especially like in peripheral T cell lymphoma, tumor cells are small, they look very benign. ALL L1, old L1, FAB types. The tumor cells blast can be very small. Look at the intensity of expression. Is it strong, weak? Is there a heterogeneous expression, homogeneous expression? Look at internal control. Has your IHC worked or not? Very important. Very, very important. Before you call PAX5 weak, it has to be very strong in the normal B cells. So normal B cells have to be very, very strong to call it weak PAX5 for tumor cells. If your normal B cells are weak, your tumor cells will be negative. And then you say tumor cells are negative, that's a wrong report because your internal control is weak. So give you an example. I think Jai gave me this slide, beautiful slide. Look at these B cells. These are the normal B cells, strong for PAX5. And these are the classically Hodgkin cells, which are weak. So this is normal B cells, strong PAX5. These are tumor B cells, which are 20 negative, but PAX5 weak. So this kind of expression you need to see in your PAX5 to call it positive, weak positive for Hodgkin's. Now, as I told you, you have to be careful with CD20. It could be the reactive immunoblast. It could be reactive. It could be tumor. As I said, RS-like cells you get in many conditions. Like this is a case of small lymphocytic lymphoma. You see these proliferation centers, hypodense areas rich in pro-lymphocytes. If you go to high part, they may be rich in pro-lymphocyte. But in addition, you find these large cells, which could be immunoblasts or para-immunoblasts, and they are 30 positive. It doesn't become composite lymphoma. It doesn't become two lymphomas. You get RS-like cells in CLL, SLL. So mimics of lymphoma. Now I go to my cases. Classically, inflammatory lesions, EBV, mostly CMV, and immune deficiency related. Then some lymphomas, low-grade lymphomas can mimic classical Hodgkin's. High-grade B-cell lymphoma, high-grade B-cell lymphoma can mimic Hodgkin's. And many T-cell lymphomas. These are all a T-cell. PTCL, AITL, ALCL can mimic. So, you know, if we have so much of problem in doing in lymph node biopsy and with so many IHCs, so FNAC will be tricky. So I would recommend strongly avoid, you can suspect Hodgkin's on FNAC, ask for the whole node biopsy. Now, needle core biopsy is in fashion. It again gives you a problem. So you have to be careful. I will skip these tables. They will be available for you for 48 hours if students want to read them. I think this is a case of T-cell with B-cell lymphoma to differentiate from Hodgkin's and NLPHL. It's a classically diffuse pattern, very pink-looking node, full of histiocytes and scattered large cells, which may be slightly more in percentage, but generally less than 10-15%, that these are the tumor cells. If I do IHCs, background will be CD3, these tumor cells will be CD20 positive. So this is not classical Hodgkin's. It becomes either NLPHL or T-cell rich B-cell lymphoma. Now, NLPHL is a type of Hodgkin's, but NLPHL has to have a nodule, a big nodule. If it doesn't have a nodule, we call it T-cell rich B-cell lymphoma. If it has a nodule and this kind of pattern, T-cell rich background, the nodules rich in small B cells and the tumor cells are also 20 positive, we call it NLPHL. Like this case is case of T-cell rich B-cell lymphoma. CD3 is positive in all cells, negative in the large cells, 20 is positive in all the large cells, 30 is positive, 30 is negative, this is also 20. EMA is positive, 15 is negative. So it's a classically case of T-cell histiocyte rich B-cell lymphoma. Another case to show you, another case of T-cell histiocyte rich B-cell lymphoma, a diffuse pattern, mostly histiocytes, lymphocytes, and some large cells in between. And if you do 20, they're all positive for 20. Now, how to differentiate NLPHL? Now, these are the two entities which give you problem in your practice. So now these are overlapping entities, and maybe they are two ends of a spectrum where NLPHL is malignant and NLPHL is benign, and T-cell B-cell lymphoma is malignant. NLPHL will always have a nodule, either one or two or multiple nodules. T cell with B cell lymphoma will be totally diffuse. Rest, they're immunophenotypically, they will be very similar. So here comes the importance of clinical. Clinically, the T cell with B cell lymphoma is stage 4 disease, means the patients, and 4B, 3 stage or stage 4, and B symptoms, means patient will have fever, loss of weight, loss of appetite, patient will look sick. These is classically stage 1A or capital A. Means stage 1 means single node and no B symptoms. So they may look, sometimes you might miss the nodule. You have to do stains, CD23 and other stains to pick up any nodular pattern. And these nodules should be rich in small B cells, and the large cells also in the nodule or outside the nodule should be 20 positive. So NLPHL and T cell histiocytic B cell lymphoma can look similar. You need to call your friend oncologist and ask him or her the clinical features. So like this is a beautiful nodule of a PTGC, and it has tumor cells in the center, which are all 20 positive. And this is a diffuse pattern, so it is a diffuse T cell with B cell lymphoma. Another case of nodular patterns of NLPHL. So presence of CD20 positive small B cells favor NLPHL. In T cell with B cell lymphoma, you don't get many small B cells. In NLPHL, the nodules are rich in small B cells. Even the tumor cells are B cells. In T cell with B cell lymphoma, only the tumor cells are B cells, no small B cells, or very few small B cells. Then there is a rosetting pattern. I will show you a picture later. You could do some more stains. Once again, a table. I will not spend time here. There again a table to differentiate classical Hodgkin's from immune-associated lymphoproliferative disorders. I'm not going to spend time here. Now, again, these tables will be coming in the blue book, the next WHO blue book. I've taken these tables from the blue book. You could do, now we have a case, interesting case to show you. Before that, I will show you a plot of flow cytometry. We get a lot of bone marrows for staging in the flow lab, and we do flow there. And in the flow lab, we realized, which others have also picked up, that if you, this is a CD3, this is CD5. Both of them are T cell markers. Now, my question to the audience is, I'll take help of Priya here. I would like to know which is the abnormal color in this plot. This gray color is abnormal, or blue color is abnormal, or the red color?
You can answer in the chat box.
There are two T cells, 3 here on the y-axis, CD5. So these are the cells which are positive for both. Sorry, these are negative for 3 and 5. These are positive for both 3 and 5. Now these are positive for 5 but negative for 3. So which is the abnormal population here?
Sir, most of the people has answered red, and I can see one blue.
Yeah, so blue is normal. The red is abnormal because these are the T cells, they have lost CD3. So now we have in our lymphoma screening tube around 13 markers, and based on this small aggregate, we have picked up many T cell lymphomas, and these are classically angioimmunoblastic T cell lymphomas, which have been diagnosed as Hodgkin's lymphoma or has been diagnosed as marginal zone by me in the histopathology maybe, or DLBL. So it's a beautiful plot to, I'll just clean this so that in case you want to see it later, you can see it. This is beautiful plot of 3 and 5, and this is abnormal. So then you do other markers. CD4 is positive in the red cells. These are my cells of interest, the red color. CD4 is positive, 8 is negative, 2 is positive, 7 is negative. This is abnormal. So this is a T cell lymphoma. It was called as Hodgkin's maybe or something else, but it is you do ICOS, you do PD1, they are positive. And we could do light chain restriction. Sorry, we could do clonality of T cells by TRBC1, T cell receptor, constant region B1. And this is showing that all the tumor cells, the red cells, are positive for TRBC1. So it basically tells you it's a clonal T cell population. So it was a T-cell lymphoma. Yeah, this is a beautiful place which I was there last week. So Suvilai. Dead villi. Once again, classical Hodgkin's has a common differential in peripheral T-cell lymphoma and ALCL. You can read it. Maybe you can see this table later. Now, how much you do, how much workup? As I told you, WHO has come up with the essential criterias, and desirable criterias. In essential, at least these 3 markers. Do not show it to your administrators, or they will not give you more than 3 markers. And if you don't have IHCs, then you show this book to your administrators. They might give you 3 then, at least 3. Now, background cells in classical Hodgkin's lymphoma. Now, 90% cells in Hodgkin's are background cells, which are immune cells. Now, let's talk a bit about that. As I told you, most of them are CD4 positive T cells in classical Hodgkin's lymphoma. They are T cells. However, B cells are more in one type of classical Hodgkin's lymphoma. And the NLPHL, the nodules are rich in small b. Even the large cells are also B in NLPHL. If you do not find the nodular architecture of LRCHL, you could do CD21 or 23 or CD35, which are FTC markers. And you could look for rosettes around the RSLs using CD4 positive T cells markers or using PD1. So my question to students and colleagues and audience here is, how do you diagnose Hodgkin's by FNAC or FNAC flow, HND or HND with IHCs? When I say HND, I mean whole node biopsy, not a needle core biopsy. You should ask for a whole node biopsy.
Sir, many are answering HNE followed by IHC and
So
clinical.
avoid this because nobody will treat. If you call anything on Hodgkin's on FNAC, you'll go wrong. I've already shown you we go wrong even on histopathology. We are expert cytopathologists in the audience, I'm sure. They might not agree with me, but we could suspect Hodgkin's and we ask for a biopsy. Now to show you a bit about NLPHL, as I showed you, they look like normal node here, but there's a big nodule here. There's another big nodule here. These are called PTGCs. P is progressive transformation of germinal centers. So here the mantle and marginal zones coincide. They lyse and they become a big nodule. They may be fusing with other nodules, and they have some. If they have a tumor cell sitting in the centers, it becomes NLPHL. Then it becomes NLPHL. But if it doesn't have tumor cells, it remains PTGC. Tumor cells should be preferably within the nodule and also can be outside the nodules. Yeah, here. So this could be popcorn-like cells. They look like popcorns. So definition of NLPHL, again, from WHO by Sylvia Hartman and her group. It is a germinal center B cell lymphoma composed of scattered large neoplastic B cells with multilobated nuclei, LP or LNH or popcorn cells. They are within the nodules, mostly dominated by mantle zone B cells and FDCs. So the nodules are rich in FDCs. You could do CD21 or 23. If you don't see nodules, these stains will help you pick up the nodules. And it has been shown that there are almost 6 patterns, morphological patterns of NLPHL. And the tumor cells express 20 strongly. Negative for EBV, weak for 30 or negative for 30, negative for 15. So they're not like Hodgkin's. They don't have morphology like Hodgkin's. The only features are they are tumor cells are scanty, very, very scanty like Hodgkin's. Very low grade. They may be like low grade marginal zone lymphoma, or they could be like classical Hodgkin's lymphoma. So somewhere in between. So this is another case of NLPHL showing you some nodules. I know that you might not be able to make out, but these you have to believe me. On a microscope, these are all nodules. And if you do 20, you see this 20. It is beautifully positive. It is like germinal center, but this is not germinal center. These all is PTGC nodule. And there are these large cells positive. All these large cells in the nodules are positive for 20. And the small cells are also 20 positive. So this is a classical PTGC nodule rich in small B cells and also the large B cells. This is an example of NLPHL. classical picture. You can see rosetting by T follicular helper cells. 30 is negative. You could pick up 20, FDC patterns. Like this is a normal follicle. This is possibly a PTGC follicle here. So as I told you, not for postgraduate, but just briefly mentioning you, there are 6 types of NLPHL morphological variants. Thanks to Yashoda, she been very kindly, she's given this page in the WHO book. There are 6 variants. There are some debates. There are some variants have good prognosis, some have a bad prognosis. But for postgraduates, I will not go into details here. There are differential diagnoses of NLPHL again. It could be just reactive node, benign. So don't make an overcall. They are classically large size node in axilla or maybe in inguinal nodes. They are asymptomatic, and the history of 1 year, history of large node, then it could be NLPHL. But if it's just an incidental, finding of PTGC in a axillary dissection or a neck node dissection, it may be just PTGC. Don't have to overcall unless until you see classical LNH cells substantiated by your immunostains. Now, this is a question for my, I think I've written the answer here. Actually, can't ask the question. Now, this is a PAX5 in NLPHL. This is weak or strong. This is strong. Why I call it strong? Because the normal B cells are also strong. This is PAX5 in tumor cells of Hodgkin's, classical Hodgkin's, where tumor cells are weak, normal B cells are strong. So here the beauty of a good quality IHC stains. We are lucky to have very smart technologists in our department and lab. They give us beautiful stains, and then only we can sign out. And manual stain gives you problems. So I again suggest, if you are doing IHCs, though it's very, very expensive to have a equipment automation in your lab, but it's a good idea to maintain good quality, doing validation, doing quality controls. Otherwise, very tricky and very difficult to maintain standards by manual method. But you see here, the first case, this is NLPHL. This is classical Hodgkin's based on PAX5. But this is just one stain. You need to see all things. Now, this is just a cartoon I've drawn to show you what is rosetting, just for, postgraduates, just to give an idea. Let's say this is a tumor cell. This is a tumor cell, RS cell. And these are cells, small T cells around the tumor cell. They all will be CD4 positive T cells. This is also a tumor cell, but not RS, or maybe RS-like. And it can be seen in T follicular helper cell lymphomas, NLPHLs, lymphocyte-rich classical Hodgkin's. It is also surrounded by T cells, but these T cells are T follicular helper cells. They come from the germinal center and they express PD1, ICOS, CD4, BCL6, CD10. So these multiple markers, they will be highlighting here. So if you do PD1, they will be positive. PD1 won't be positive here because these are the T cells, CD4 positive helper cells. These are the T follicular helper cells. So these are follicular helper. These are just helper. There's a nice road to Jhanskar Valley. Means we get lots of needle core biopsy. Now, this is a case of NLPHL, which we spend a lot of time. We had to do 2-3 biopsies. There are nodules, there are tumor cells, but diagnosing NLPHL on needle core biopsies can be crazy, difficult problem. So needle biopsy has its issues, but you can sort out the issues if you have a lady in your team. We are lucky to have Shweta with us. I go to next case, 35 male generalized nodes, some supraclavicular node. Now, read the history, supraclavicular. When you say supraclavicular, you know that it's part of mediastinum. So you have to be thinking of Hodgkin's, gray zone, primary mediastinal B-cell lymphoma, or metastatic carcinoma. You don't get TB there. You don't get other lymphomas commonly there. So again, you see a node with fibrosis, nodules, some necrosis, lots of histiocytes, and a lot of tumor cells here, clusters of tumor cells. So fibrosis, histiocytes, necrosis, sheets of tumor cells, necrosis. These cells, many. So we thought of Hodgkin's ALCL, we did markers, I'll quickly go through because we're finishing our time. So here background is rich in T, but all the tumor cells are 20 positive. So now this strong 20 positivity, I'm not going to call it Hodgkin's, though 15 is positive here, beautiful. 30 is also positive, beautiful. So I'll skip it. PAX5 was positive, other markers were positive. I won't spend time here. It was called as a gray zone lymphoma based on morphology, strong 20, and the site. So I think these are the important messages for postgraduates. Look at the tumor with the history, clinical findings, then morphology, then go to the IHCs. And then, you give a final diagnosis. So it helped us. The site also helps you. So now this gray zone lymphoma is again a B-cell lymphoma, which has very overlapping features between PMBCL and classical Hodgkin's. And which type of classical Hodgkin's? Nodular sclerosis. So in mediastinum, we have nodular sclerosis, classical Hodgkin's, we have PMBCL, and we have gray zone lymphomas. And in young kids, in mediastinum, we have which lymphoma? Who come to casualty with gasping. So a young kid comes to casualty with gasping breath, and you have X-ray, you find something there, and you do peripheral smear, you might find blast. T lymphoblastic lymphomas are very common cause of young kids coming to emergencies. Again, a beautiful wonder. This is a pink lake because of algae producing carotene, and this is a bay of the South Atlantic Ocean in Namibia last week. Lucky to be there. Next case, 63 male comes to us with generalized nodes. Now, this is the age. You look at the age, elderly, generalized nodes. The case I'm showing you because we had called it Hodgkin's, but we finally called it as AITL. We initially called it Hodgkin's, and I'll show you. We had a lot of debates in the whole Bombay group. We have a big Bombay lymphoma group where we meet once a month. Now, post-COVID, unfortunately, we've not been meeting. Hopefully, we meet again. If Kunal is listening, I'm sure he's not here. But all of us thought of classical Hodgkin's. So large node, the quality is not very good. Diffuse pattern, pink-looking node, and many RS-like cells. You see this mummified, binucleate. Background is rich in lymphocytes with minimal ATPR. Minimal, lot of histiocytes and RS-like cells, and eosinophils in the background. A lot of eosinophils. So we thought of Hodgkin's. We did 3. Background is rich in 3, though there are follicles, many follicles. Generally, you don't see many follicles in Hodgkin's. If you find many follicles, you think of AITL, but that morphology was Hodgkin's. 20 is negative in the large cells. Some cells are weakly positive and some cells are negative for 20. So 20 was like this. 15 was positive in the large cells. EBV LMP1 was positive. PAX5 was weakly positive, very, very weak. And 30 was positive. But 30 looked very, mostly very cute looking mononuclear cells. But putting everything together, we thought of Hodgkin's. We called it Hodgkin's. But later on, we called it AITL, and retrospectively, we did more stains, BCL6, 10, and we found large population of these cells with CD23 and PD1. But I think I will go to why did we call it AITL? Now, the sample had gone to the flow lab for staging, and there again, we saw this CD3 and CD5 plot. Now, which is the abnormal population here? Blue, red, or gray? Of course, red. Why? Because CD3 positive cells, these are T cells which express 3 and 5. These are 5 positive, 3 negative cells, CD3 negative. So there's abnormal. So these cells were all positive for all markers for CD185, which is CXCR5, PD1, SU79, ICOS 278. They're all positive, the red cells. Weakly here though, but 10 positive. HLA-DR positive in T cells. So it basically was AITL. Then we did the clonality. It was clonal T cell population. So why I'm showing you this cell is basically to share, if you have a doubt in a diagnosis in lymphoma, it doesn't look like classical Hodgkin's, be careful, doesn't fit into the age. Look at the background cells. Look at full panels, look at the rosetting, look at the FDC patterns, not only 1530. So it becomes more complicated for us to diagnose Hodgkin's. We used to think it's the easiest diagnosed lymphoma. So now here the background small cells look very innocuous, benign. You could call it Hodgkin's, you could call it, there are some small, there are some intermediate cells, some, but they may look like histiocytes, there are immunoblast-like cells. So maybe all the large cells are immunoblasts. All these cells like these are immunoblasts. They are not RS cells. And the cells of interest are the small cells. These are the neoplastic cells. That's why it's T cell lymphoma. You could see so many eosinophils here. So this is an important and interesting observation, has been published a couple of years back, and we have seen many, many cases in our lab, and we, based on screening tube, we suspect and we suggest, and then we work up, and many cases of other B-cell lymphomas reported by us, by someone else, have been reviewed and changed the diagnosis. AITL can look like anything. AITL has different stages, early, late, intermediate. Early stages can look like follicular hyperplasia or follicular, there could be follicular T cell lymphomas, follicular pattern. I think I'll skip this case. This is a case of rheumatoid arthritis, which mimicked Hodgkin's. Dr. Borges' case. There are these large size mononuclear cells, many, and lymphocytes, histocytes in the background. There are these mononuclear and binuclear cells. And if you do 20 positive strongly, 30 positive strongly, Eber-ish positive strongly. So it is not Hodgkin's, Bob1 positive strongly. This is classically EBV associated proliferations. So again, my request and message to young pathologists, just be aware of this entity. We have many benign EBV proliferations. They may proceed to become Hodgkin's, but if you are not sure, take a second opinion. It's better to call it benign at this stage, maybe follow up. Look at the history. Are they under any immune suppression, age, very elderly, or some drugs?
Excuse me, can I ask a question?
Yeah.
In this CD20 strong positivity was the reason we didn't.
Yeah. This CD20 strong positivity is very unusual for Hodgkin's. Now, this may turn out to be Hodgkin's later, but I can't call it this 20, this 30 positivity. No. And the cells do not look classical. They look more mononuclear. You can see the word cute looking immunoblast, not like the dangerous looking RS cells, and 20 strongly positive. Though I'm not showing you, even the transcriptional factors are strong. I'm not showing you other markers for T cell, others, but this is classical of PAX5 is also pretty strong. OCT2 is strong. So can't call it lymphoma. So similar tonsillitis. So I think I'll skip these 2-3 slides. I'll go to a case here. A young boy came to us with fever, weight loss, and right-sided cervical swelling. A biopsy was done. Here I will need help. I'll need the audience participation. This is my last case. A young boy with fever, weight loss, cervical swelling, lymph node biopsy was done. You could see a capsule which looks like thickened, and you can see some lymphohistiocytic lesion with so many histocytes, pink looking lesion, and some hyalinization, RS-like cells, so many eosinophils here. So any diagnosis? So many eosinophils, hyalinization, capsule, young boy. Cervical node. Single cervical node, right-sided.
Please
Okay.
answer in the chat box.
Again, RS-like cells and many eosinophils.
So Dr. Atul has answered NLPHL, Shayla's nodular sclerosis,
Eosinophils, Atul Shala says, nodular sclerosis, but okay, yeah.
and Dr.
Nodular
Anil
sclerosis.
is in Kimura's, not lymphoma.
These cells in Kimura's, okay. These, you don't think these are neoplastic? You think they are benign? Okay. So again, these cells, you look bizarre looking cells, many. And eosinophils, kind of rosetting, but eosinophils are rosetting the tumor cells here. So if you look at, we did IHCs now. IHCs, LCA is negative, 20 is negative, EBV is positive, 30 is positive. So now people would like to revise their diagnosis. Young boy, capsule, fibrosis lesion, tumor cells, look like RS, but mononuclear mostly, a lot of eosinophils, single cervical node in a young boy. Eosinophils, blast, tumor cells, only positive for 30, negative for 20. Anything you want?
Infectious. Infectious mononucleosis.
Tumor cells are there. Anyway, so we did, anyway, this is a quiz for anyone. Anyone can answer this question? Which movie is this? The famous song, Hindi song, Indian students, I'm sure most of us are Indian students here. There'll be few foreigners, but Indians would have seen, at least of my generation, must have heard the song. Do you know Priya or Asta? Diksha?
So Saya?
Very good. Mera Saya, yeah?
Yeah.
Perfect.
Mera Saya.
So Mera Saya was, I think, the heroine was Nanda, Babita, I'm forgetting. Is a old
Sadhana,
movie.
Sadhana sir.
Sadhana, yes. You score more than me. So I'd gone to Bareilly and they have hung a jhumka in the market. Cytokeratin was positive strongly here. So if you have a sick, young boy, cervical node, you have to keep undifferentiated carcinomas. Nasopharyngeal carcinomas also can mimic. I didn't show you PAX5 that time. You should have asked me. So, so this is I basically not in this context, but otherwise, please see lymphomas in scanner view, because if you go close, every tree looks like a snake. Otherwise, if you need to have a scanner, 2x or a 4x, otherwise we have problems. So to conclude, I have told you many differentials of Hodgkin's, from viral infections, CMV, EBV, to low-grade B cell, to high-grade B cell, to T cell, and to carcinomas. So FNAC can be tricky. Now, there are three situations here. There are three lymphomas. They look similar because they're mostly small cells. Large cells are scanty. They are there. No, but they're all different. This is AITL. This is peripheral T cell lymphoma. This is a classical Hodgkin's lymphoma. So it can be a problem. It has eosinophils here. See the eosinophils? It also has eosinophils. The T cell lymphomas can have eosinophils. So background, you have to spend time. You have to understand. Maybe you take help of your immunophenotyping. Maybe take help of flow. And obviously you start from your clinical morphology and a host of markers. If you have a doubt, please take a second opinion from your next door neighbor. Even if you don't talk, many of us in our departments, we don't talk to each other, but it's a good idea to take opinions and give opinions, serious opinions. So it's a multidisciplinary diagnosis, lymphomas, not only morphology, no, and not only IHCs. Your morphology, if it is wrong, you'll ask for a wrong IHCs, and IHCs will doubly make you wrong. You have to be careful here. So this is our Bombay Lymphoma group. We have to meet. We have not met long time. And my colleagues in my department, and the young boy, Divakar, took many pictures today, and Tushar also has helped me in the last few days in my reporting. My colleagues Tanuja and Shirdar and Uma also has joined us. This is my team from ACTRAC. Thank you very much.
Thank you, sir. It was a wonderful talk, and you aptly highlighted the nuances of morphology as well as IHC.
I have with me Lingraj. Lingraj, you have to unmute yourself, and I would like to have your comments, please. Lingraj is a colleague medical oncologist in Tata Hospital, and he does lymphomas with great passion. Yeah, Lingraj.
Thank you, sir. Sir, am I audible?
Yes, yes.
Yeah, thank you, sir. Thank you. So, I mean, it was a pleasure to listen to you, and I can think about my lymphoma clinic moments also. So, thank you for that excellent lecture. So, I will just put 2 points. As a clinician, you discussed about the mimics. So, as a clinician, where do I really want to be doubly sure about lymphoma? Because Hodgkin's lymphoma, the treatment is something which is little less intensive, and you go slow. But when you talk about gray zone lymphoma, when you talk about T cell lymphoma, where the treatment is little intensive, so and you have only one chance to treat these patients, that is the first time they are diagnosed. So if you treat a gray zone lymphoma like Hodgkin, and then after that you get to know that was a gray zone, I mean, you can't, and the outcomes are definitely very poorer. And same thing is for T cell lymphoma. And that's what these are the two situations which are really very common in day-to-day clinical practice, that a gray zone lymphoma and a T cell lymphoma, you should not misdiagnose as Hodgkin, and because they require something more than the treatment of Hodgkin. And yeah, so these are the two things that I wanted to make a point. And anything else, if anybody want to ask anything about the clinical aspect, I'm happy to answer, sir. So, and thank you very much for calling me, and it was a lovely talk, sir. Thank you, sir.
Audience, if you have any questions, you can put in the chat box.
I think there are no questions, no comments. You have anything to say, Priya, your experience or?
Sir, it was such a, I mean, relevant talk for all of us because every day, like, we come across Hodgkin cases and there are so many mimics. Like, even at, we take second opinion, like you told, and it was like summed up all the cases you have shown. It was like really nice. Even we have doubts every now and then. We have doubts. Sometimes IHC also might not help. IHC might not come out very well, and we look back on morphology and see what it is. We look on the background cells. And thank you, sir, for such a wonderful talk and showing us all the cases with the flow plots also.
Yeah, I mean, there's a question by Venice that do we get neutrophil sprinkling? Yes, we get neutrophil sprinkling. We get neutrophilic abscesses also. You get necrosis in Hodgkin's. You get granulomas.
Granulomas.
So I didn't talk about those differentials. I'm sorry, I should have mentioned that. You get neutrophilic abscesses. You get granulomas. You get necrosis. You have to be careful. Granulomatous, we called it, but maybe Hodgkin's. That is why FNAC, you have to be a little careful there. Thanks, Manisa.